I'm really excited to talk about this because I think this, a lot of times systems work in parallel, right? And they don't realize what other folks are doing. So I'm excited to share a little bit about what this looks like from the school side. This is us. I'm Rebecca Pope. I'm a school social worker, worked in a number of different roles in school-based mental health, and then some community-based clinical work as well. My pronouns are she, her, and we're here in Sonoma County in California. I'll let Wendy introduce herself.
Yeah, thanks so much for having us. I'm Wendy Worms. I'm also an LCSW and a PPSC, which is a licensed or a credentialed counselor. And I've also worked in school-based mental health for many years now. We're happy to be here. Thanks for having us.
And I think I know this is a meeting that includes folks across the country, so I think it's helpful to talk a little bit about where we are, because what we do might look very different in other states and in other counties, even within our state. Our specific county looks like this, and it's in our county we have 40 school districts, and you can see all the statistics of who is involved. So there's a lot of you can even just see by this map, there's a lot of variation. We have some pretty densely suburban schools, and then some very rural schools. We have a school that's about 2 hours north of the center here that has 12 students, K through 8. And then we have schools that are, more conventional, with hundreds or thousands of kids. So it's a pretty wide range of kind of of who we serve and who we are. And there's a really wide range of needs. Our county, our youth suicide rate is 25% higher than the state average. So it's a pretty significant issue for us. There are many factors that play into that. But ultimately, it's something that we're really concerned about and really working hard to change. We do a survey every year with just about all of our schools. And some of the key questions that we ask in an anonymous survey, it's called Youth Truth, but it tells us really important things about our students. And this past January, surveying high schoolers, what we found is that 35% of them reported pretty significant levels of hopelessness and sadness. 13% said that in the last year they'd seriously considered attempting suicide. And I think for us, that is this indicator that, that is our kind of gauge of mental health, right? These are among the ways that we assess how are our kids doing. Are they thriving, right? And so this is a sign for us that we have some work to do.
So we're not sure how familiar folks are with schools, but in schools, we use something called the MTSS framework, so the multi-tiered systems of support. We think about services and supports in the universal tier. So the first tier is, what are we doing around prevention? What are we doing for all students? So that could be SEL or mindfulness strategies in the classroom. It could look like positive behavior intervention supports. But tier 1 would be, what are we doing to support mental health and wellness for all students on a campus? Tier 2 would be more targeted interventions. So what are the small groups we're running? What sort of meetings are we holding to talk about and kind of strategize for students? What programs, affinity clubs, affinity groups, things like that will support students' mental health. And then finally, tier 3 is where we see the one-on-one support, either through school-based counseling or sometimes an IEP service. This is where more of the crisis response and the risk assessment would come in at a school, as well as like reentry plans or support for students after they've been hospitalized.
I think
Rebecca, yeah.
Yeah, I'm just, this is actually our structure that's familiar to school folks, because this is actually the structure of how we consider academic supports. And so this has been a recent shift, really. I think in our county, but I think nationwide, of really understanding that schools are more than just a place to teach kids. That this is really the best place to get to like support and serve kids, because this is where they are all day long. And it's really a center that could be beyond just academic, right? And so while we used to think of this as, what is the reading curriculum you use is the universal support, what might be a small group curriculum, or what might be, giving a student an IEP for academic supports, we've shifted that model into social, emotional, and behavior supports as well, which is a framework that really works well in schools because teachers and staff understand it. And we can use it to really help support mental health and for our students. And these are examples. There are a lot of acronyms in here you may or may not be familiar with. Every industry has many acronyms, obviously, but it's really this concept of like, we want to meet kids where they are. The more that we can provide level 1 and 2 supports that are appropriate, the fewer kids get to level 3, right? And then the way this ties into mental health supports with doctors and with maybe emergency rooms is like that. That's very much kind of the tier 3, right? Like working on supporting students in that tier 3 are the students that maybe come back from a hospital or need to be referred by the school for emergency or crisis supports.
Only thing I wanted to add before you go to the next slide is that schools have typically, interestingly, focused on tier 3. And I think because most kids have sort of funneled to tier 3, it's made it such that sometimes even the tier 3 support is not as robust as we'd like it to be. They're trying to support too many students in tier 3. So there has been a move recently to really shift to focus on what are we doing in tier 1 and tier 2, so that by the time kids are getting to tier 3, we really know that they need the support and we can offer something that's more quality and more focused.
Thank you.
Yeah.
This is just a brief slide. This is kind of what I know you all did a listening session and you had some amazing recommendations and gaps that really resonated with. I said, yes, I agree with all of these. This is absolutely where the concerns are. This is absolutely what we need to be supporting. Some of the reasons that schools really struggle to support student mental health is, number one, they were not designed to do so, right? We're designed to meet the needs of the kind of privileged dominant culture, and it does great for that, so if you don't have any other needs, you do great in school. But we're not really structured funding wise or staffing wise to support mental health. So this has been a big shift. One of the reasons that schools struggle to do so, according to schools, is just that many things that we'll talk about a little bit more, but there really are, we struggle to hire mental health professionals, especially culturally responsive mental health folks. There isn't enough money, all these things that you might say, that sounds about right. This is what gets in the way. And then specifically, there are some additional complications because of the system that we are and that we're shifting to become, and then also like working with other systems, right, that are equally as kind of have blinders on and just can do their own thing and really struggle to mesh. So really additional challenges specifically for schools is if a student gets hospitalized, if a student has to go to the emergency department and maybe receive more intensive care for a while, it's pretty hard. It's pretty hard for schools sometimes to even know that that's happened, let alone be able to connect with the hospital or the treatment center to get recommendations, right? Like there's usually a safety plan and a treatment plan, and it involves recommendations for schools. Unless we are like ferreting that out, it is hard to get a hold of that often. And sometimes we can't, depending on what system it is. Unless, yeah, it depends on also like, family engagement. Some parents come marching in with it and give us a copy. And some parents are like, oh yeah, someone gave me a paper. I don't know where it went, So it very much depends on kind of the capacity of the families. And that's hard, right? Because obviously the families are impacted in this situation too. It's hard to be on top of all of that. We often mental health providers look like me, lovely, very kind, middle-aged white lady. And that is not necessarily the most appropriate person to be connecting with our students, because many of our students do not look like me and don't feel heard necessarily by me, as delightful as I am, I think another thing that is hard for schools is really focusing, like Wendy was talking about, this multi-tiered support, really shifting from like everyone gets the same thing except for our crisis kids, and really kind of doing this multi-tiered approach to support kids in the middle that really don't need the level 3, don't need that crisis support. We really can intervene earlier. Let's see, move on so that we get through this. I guess we're talking too much. In our specific county, we don't have psychiatric beds for children. We have one private hospital that has psychiatric beds for teens. Sometimes teens can access it, sometimes they cannot, depending on their insurance, their point of access. They often end up 2 hours away. And it's very hard to find them if they're somewhere outside the county. And there's no system for reentry supports that is like a universal that everybody's on board with to be able to communicate with the school around that.
Okay, so there are lots of challenges, but there are also things that are working. So I think one thing we see in schools right now is really a move towards wellness centers or school-based health centers or schools as centers of wellness. There's sort of lots of different names for that, but essentially it often means moving down to focusing on more of that tier 1 and tier 2 intervention, and also really building community partnerships to bring more mental health providers onto campus, but also physical health or sexual health or other partners to support health and well-being for students more broadly. It's also very successful when there is a licensed clinician on campus. One thing that that is really does support, it at least makes clear who the human is who will try to reach out to the hospital or to the family or to the doctor. Without that person, often at schools, it's not clear like whose job that is. And sometimes it becomes no one's job. So in our county, on most high school campuses, there is a licensed clinician at this point.
At least one day a week.
At least, yeah, some of them are full-time. It's very, in our county, yeah, it's very inconsistent. So there's nothing like across the board, because as Rebecca mentioned, we have 40 districts, so people do things differently. Some of them are temporarily funded through COVID money, which will become problematic, but others have found funding and made it a priority. We have also looked at really trying to use the staff we have. So in terms of risk screening in particular, really broadening like who has the skills to do that. So we are trying to train school counselors in particular, although other folks on school campuses, to be able to at least do a risk screening or some sort of basic mental health support. Until now, there's been I think sort of a reluctance and a discomfort for folks who are not mental health providers to do that. So we're trying to use the staff we have, and really increasing the value of other adults. So in our county, we have positions like community health workers and family liaisons, restorative specialists. They're oftentimes folks from the community who are really great at building relationships with kids and families, but may not have a clinical background. And we have found that they can be quite effective in supporting students. So we're trying to really increase the breadth of who the humans are on a school campus that feel comfortable providing mental health, wellness, social, emotional support for students, so that as students rise through the tiers, the licensed mental health folks, the few that are on campuses, can really focus more on that tier 3 and that connection with outside agencies, whether it be a hospital or other agencies. Okay. Other things that are working clearly published, we talk a lot about visibilizing mental health support on campus, both as a way of destigmatizing it, but also as a way of helping kids access it. A lot of times kids will report that there are no supports or services available to them on campus to help, but it turns out frequently that's not the case. So we've tried to really support folks in making more visible and clear to kids how they can access the mental health support that's available on campus. I'm sure you're all familiar with 988. 988 has actually been a huge support to schools. It's like incredibly helpful to be able to, as we do, Rebecca and I do some suicide prevention in our county, and to be able to give kids a number that they can remember easily, that they can text instead of call. That has been incredibly supportive. Our county is making an effort to understand and use universal screening tools more. I would say, again, there's sort of a hodgepodge of what's happening, but it is helpful to us to be able to identify students who need support more proactively. And in our county, we are seeing some increased community partnerships. That we have something called the SAFE team as an example. It's really an interagency partnership that can come to campus and respond if a student is feeling suicidal at school. So if there are not mental health providers on site, we're seeing that there are teams who can come and support that assessment process without it being the police, which is quite supportive to students as well as to staff. I see a few things in the chat, Rebecca, so maybe
okay.
Yeah, I'll check.
Should we finish this and do questions at the
Yeah,
end?
yeah,
Okay.
that sounds good.
Great. So we just have a couple of thoughts about just recommendations is what we would love to see in the future is, and we were talking just as in general to health providers, because I know they also struggle to connect folks to mental health supports, right? So from like a physician or a pediatrician standpoint, I think we would recommend, just as we're kind of scrambling to do as well. And I think a lot of systems are just really trying to connect with the other systems, even though sometimes it feels like banging your head against the wall because all these systems are designed very differently and have different language and different protocols. But just in your area, figuring out how these local systems work together. Sometimes they actually do work pretty smoothly together, and there are things you can connect to. And I think because part of the concern is that, parents of students in crisis are also in crisis, and really high functioning parents may be able to connect to these services, but often they really do need help. And if both the school and the doctors or the hospitals are aware of community agencies and community supports to be able to help these families, then that is, if we're both saying the same thing, that's a huge help. And often, if possible, the warm handoff, making sure that connection is made. And I think what we've, just maybe don't forget schools. Like when you have conversations, like ask up front, what school does your child go to? Can we I'll send you a release of information with you that I've signed. Hand this to your school counselor, hand this to your school principal, so we can immediately start that conversation. We don't have to be tracking down the other folks. And then some, within a hospital, sometimes there are systems that exist, sometimes there are not. So just making sure you're aware of what those are. Yeah, well, there we go. And I think that's our little summary. So we have time for questions or to respond to the chat. Oh, well, thank you. I got a little hand clap in the.
Yes, one question in chat. Are there liability concerns with non-licensed individuals, i.e. school staff, completing mental health screenings? Have you run into any issues around that?
So a screening, and this is something that we've had to ferret out as well, right? A screening is not an assessment, right? A screening is like, let's identify kids that have more needs, right? A lot of times schools shy away from that because then they're like, well, what if we find these kids and we can't support them, right? What do we do about that? And I think that's an important conversation for a school to have because those kids still have needs, right? They're not going to disappear because you haven't figured out who they are. So I think what it can do is inform, like if you are identifying a specific need around grief, around whatever it is at your school site, then you can better target supports that you put in place rather than just scrambling to react to the ones that are the high flyers.
Yeah, that's really helpful. We've been having many conversations, one around the differences between triage, screening, and assessment, which can kind of confused with each other. And the other is hearing across the country so I think the majority of the meetings that we're having, the difficulty with the fact that mental health systems are often siloed away from schools, which is where the kids most are.
That's right.
And often the only time like they can access it, right? Depending on transportation or access to internet.
Exactly.
So,
Any other questions?
I guess I have one. Do you have a suicide screener that you found fits the school context? Columbia versus ASQ or PHQ, which isn't exactly a suicide screener, but has one item. I guess I'm just wondering if you've reached standardization on tools that are appropriate to school context.
Rebecca, do you want to speak to that or do you want me to?
yeah.
I'm happy.
Yeah, go ahead. I'll let you go ahead.
Yeah, we do use the Columbia. So, one thing about our role as the county office is we can't really prescribe what all the districts use. We can suggest and we can recommend. And Rebecca has, most recently authored a great toolkit for our county office that we're going to share. And yeah, it really is the Columbia that we're recommending. We worked with Dr. Stephen Brock a bit from Cal State Sacramento, and he has a teaching tool that has been really helpful to us in terms of just like fleshing out the Columbia a little bit for some folks, but that is our go-to tool.
And we're doing that just because California, the CDE has basically helped do some trainings around using it in schools. And so I'm sure we're just trying to use it because I think it's the most familiar to folks and there's the most support around training for school folks that are using it. Yeah. So.
Well, thank you.
Thank you.
We have just a few more minutes if there are any questions, or if not, I think Dr. Jet Milani is in the group and we can go ahead and start him. Any final question for this? And thank you for this. It's really important to be able to include the school piece in all of this.
There is one more final question in chat.
One more final question. How do you ensure continuity and continued mental health services during school breaks?
Mm-hmm.
We do on a case-by-case basis. I think a lot of what we do at schools is try to refer folks to community supports if that's possible, just because often that is more sustainable for this exact reason. And also, if school is the only place a student's going to be able to get mental health supports, that's where they get it. They probably won't get it during breaks. And yet they're going to get it more than if they didn't have it at school at all. So it's kind of a case-by-case basis, depending on, are there community supports, to refer to in that small community, or is it a bigger area where that's easier. So I guess the answer is we cannot, but we do our best. So.
That is the answer.
Mhm.
Fair point. Fair point.
Thanks for having us, guys.
Thank
And
you all.
we put our email in, and you're welcome to. We would love suggestions. I think yeah, questions or suggestions either.
You sharing resources. I think that's great. We're looking forward to getting those. And again, thank you for coming and talking with us. Appreciate it.
Thank you.
Thanks. Take care.
it.